Good day. My name is José Augusto Miguel, and I will be your moderator for this session. On behalf of the AO, we welcome you to the presentation entitled Simplified Mechanics for Aligners in Treating Complex Cases with Dr. Chris Chang. If time allows, Dr. Chang will entertain questions at the end of this presentation. Please submit them anytime during the presentation using the questions window. We will address them if time is available. With that, I will now turn it over to my Anglo Midwest friend, Dr. Chang.
Thank you, Jose. It is a great honor to have my dear friend Jose as my chairman. My topic today is how to simplify your mechanic for aligner, which are a very difficult case to solve. So if I have a case that I cannot figure out how to fix it with aligner, probably the easier and straightforward answer will be do some pre-aligner also. And that brings you to the topic today. Before we get into our topic, I would love to pay special thanks to our president, Dr. Chris Roberts, and the whole organizing committee of AAO. It is very difficult to make decisions at this difficult time. Thank you for your contribution to our specialty. When you see a camera like this that indicates the slide that I'm going to show you contain very important message. So I would strongly suggest you to get your iPhone ready and take a photo. So you will have the material that is easy for you to review the information in this lecture. iPhone alone can get the job done. This is a Christian from Taiwan. I am member of Midwest Anglo Society, and I currently practice in Taiwan. Last year, we talked about 12 tips for aligner. And today, we are going to focus on number 2, which is pre-aligner treatment. For the case that contain extrusion, uprighting, big space crossing, posterior cross by rotation, and impaction, sometimes I will spend maybe 5 to 6 months to do pre-aligner treatment, which will help me tremendously when we get into the aligner procedure. And that's why I'm going to share with you the pre-aligner also treatment. And there are 2 reasons why pre-aligner also is so important. Number 1 is from mechanic perspective. Think about it. Aligner is good for pushing, but if you have impacted tools and you have to pull them up, aligner simply cannot execute that pulling mechanic. So that's how this screw come into play. So if we can combine screw, which is pulling, and aligner pushing together, and I think that will be perfect companion. And the second reason is from current study. And there are a lot of studies talk about the weak point of aligner. And today, I'm going just to give you 4 articles, which I believe is very important article. The first one talk about extraction. And this is by far probably the best aligner study that I have ever studied with. In this article, they conclude that the difference between clean check and the real result in patient's mouth happen to be, for the incisor, you have torque loss. Q stands for torque, and extrusion as well. In the molar, you have anchorage loss and intrusion because the aligner covers the posterior, the occlusal surface. That's why when patient bite it with aligner, they intrude the posterior. And it is very difficult to intrude the incisor, the other way around. So keep that in mind, that torque loss and extrusion for incisor and extrusion for incisor and intrusion and anchorage loss for molar. The second article from Brent Lawson talk about non-extraction, and they conclude that maxilla expansion, rotation of round teeth, incisor intrusion, and second molar are very difficult to execute with this aligner. And the number 3 talk about upper arch expansion, and the conclusion was the majority of the effect of upper arch expansion is tipping. The body movement is only 36%. So they propose to solve that problem, you can add buccal root top. And this is a wonderful article. They use the Combin CT to show you the tipping result of this aligner. Finally, we talk about the inaccuracy. For the intrusion of incisor is difficult. Rotation of the canine is very difficult. So we put that 4 articles together. That's the weak point. By far, we find that the common ground that most study will show you the similar result. The aligner have those weak points. And when you're going to deal with those weak points, and people suggest, when planning the clean check, to design their biomechanics rather than merely as a tool to visualization of predicted treatment outcome. I think it's quite true. When you look at the clean check, you should be able to have the idea to design the mechanic, not just to look at the result. And how can you do that? Pay extra attention to more challenging tooth movement. Modify attachment. Number 3, build specific overcorrection. But the question is how? What kind of extra attention we supposed to pay? So the possible solution happen to be, number 1, screw. If the aligner cannot execute the clean check tooth movement, we can add some screw for sure. Add some power reach, add some attachment design and overcorrection, etc. Number 5, etc. I would love to add this Hwai aligner also, which is my favorite. That's why I'm going to show you how I use this Hwai aligner also to help me to solve those difficult cases. With that, I'm going to organize that 6 situation that I use Hwai aligner also. I bet you cannot find number 7. Only 6 situations that you need Hwai aligner also. Number 1 is extrusion, because extrusion need a pulling mechanic, and aligner simply cannot give you a pulling mechanic. That's why you need a Hwai aligner also. Upright the motor, very difficult for aligner. For example, how would you fix 7 and 8? One is mesial tilt, the other one is partial impacted. So our plan will be move the 7 forward and upright, and then upright the 8 and move forward. It is possible in clean check, but in reality, it will be very difficult to execute this tooth movement in your patient with the aligner. So 9 months braces is easier because this wire is so powerful to upright and finally close the space. And look at how much we upright the third molar, and we also close the space as well. 9 months braces easier. And then it's ready for you, for the aligner to take over this case. And it will be very hard with aligner only. Upright, extrude, close molar space. Easier with arch wire. Difficult with aligner. That's why I choose to use braces for 9 months. How about big molar space? We talk about big molar space. If you try to close this molar to move the second molar forward, most likely you will meso-tip the second molar. What I did in this case, I used 5 months braces with buccal mechanic, and I'll be able to close the space. And down below, I also close this first molar space as well. Just 5 months. And now, it's easier for aligner. For the clean check, it becomes quite easy to fix this case. And we still have the open bite to deal with, but open bite is easy for aligner. The problem is deep bite or big space. So that brings us to the next topic. How do you solve deep bite? If I have deep close by, a spatial close by, and deep anterior like this, wow, how do you fix this anterior deep by? Deep anterior close by, very hard for aligner. And this case, I think, is insanely difficult. So I don't want to talk about this case today. Let me find the other case, easier. Oh, this one is easier. This one is okay. So we start with this one. And if we have time, we go back to that difficult case because that would drive me crazy, that case. And this one is easier. Deep anterior close by is hard for aligner. But if I tell you it only took me 3 minutes to fix this case, would you be surprised? Huh? Just 3 minutes. The way I did it was I used this anterior biturbo, which is flowable resin, to build an in-kind plate. It took me 3 minutes. It's easy yet powerful. With this 3-minute anterior biturbo, when the patient bites it, they have to bring the upper incisor forward. They have to. They will. They should. 4 months in treatment. Did you see the difference? Used to be the posterior open bite is huge. Now it start to settle the posterior open bite and the anterior close bite gone. And now it's ready. Only 4 months. Now we are ready to go for the aligner procedure. In other words, my 3-minute anterior biturbo turned the difficult situation into an easier one. Just 4 months. In just 3 minutes. And look at that cephalometric. From severe anterior close by and very deep, now is ideal. Oh, I love this approach. And it only took me 25 aligner to fix this case. Imagine if you didn't use that 3-minute biturbo to fix this case, this anterior crossbar. It probably would take 50 aligner. But now I only need a 25 aligner for this case. Isn't that amazing? That 3-minute anterior biterable can save a lot aligner. When you save aligner, the number of aligner, you save the world, the planet. I love it. Only 25 aligner. One more. Okay. How about this one? Deep anterior crossbar. Hard for aligner. Very difficult. Just 3-minute anterior biterable, easy yet powerful. And that's it. And I have the patient to bite it. In 5 months in treatment, guess what? Watch carefully the canine. Did you see the canine would drip backward because we take 4 out because of the severe crowding and protrusive lip? And when we take the premolar out, the canine, the pluck out canine, will drip. So you just give the patient time and let them drip backward to this resistance area, which is extraction socket. No resistance. That's why the canine will move to this direction. And from this set, we turn a very difficult class 3 anterior crossbar into a very easy case. And now it's easier for aligner. Hardest one. Oh, this one is very difficult. Class 3, T-bar asymmetry, multi-day occlusion. The trouble is, he is a boy. Normally, I don't fix multi-day boy. They are big trouble. But unfortunately, I already fixed his wife. So I have to fix this multi-day boy. No choice. So I decide to figure out how to fix this severe anterior crossbar, deep-bar asymmetry, and multi-day occlusion. And look at that asymmetry. This ramus, this diagonal. Very difficult. Again, normally I don't want to fix multi-day boy. Multi-day girl is okay, but not boy. I have difficulty to deal with boy. Don't get me wrong, I don't have sexual discrimination. I just prefer to work with female, that's it. And when you look at the profile, the CO profile look very terrible. But the CR profile is quite straight. I love this straight CR profile. If the CR profile is straight, the CR profile is okay, maybe I can try non-OGS for this case. And the patient prefer non-OGS. So I'm going to give a try. So how do we fix this one? Oh, I don't like this bridge. I don't like it. So I just replace with this new temp. Look at that gingival margin. After the temp, it's much better. I love this one. So he is okay with 6 months braces. 6 months. Guess what? That is my bracket setup. On the top, I use standard. Down below, I use high top bracket. Because the company didn't produce a high top bracket, they have low top bracket. So in order to get a high top bracket, I fit upside down and it becomes high top. Why? Because when I retract, I don't want to reach a kind of low incisor. I want to have the lingual root top in the low incisor. Because I'm going to use a lot of class 3 elastic, class 3 mechanic with biterable right here. And sometimes I will raise posterior biterable to have a stable occlusion. And it only took me 3 minutes. Easy, yet powerful. Oh, I love this one. It only took me 5 months. Braces. Can you imagine? 5 months. We be able to turn this difficult situation into an easy one. Look at that deep anterior crossbar has been solved within 5 months. And how do you get this huge change, Chris? There are 3 keys in class 3 mechanics that I would love to show you. Oh, I love this one. How could that possible? Just 5 months. Key number 1. Biter ball. Oh, of course. You want to fix the anterior crossbar? Biter ball is the way to go. It's easy and powerful. Right here. With glass, with flowable resin. That's it. Number 2. Class 3 mechanic. Early light show elastic. But this early light show elastic has a mechanical flaw mistake. You're not supposed to hook on the upper second molar because the open coil spring is going to push the upper second molar backward. Why you want to hook out this class 3 there? So I don't like this mechanic. I would prefer, because it's hard to upright 7 due to the class 3 mechanic. So I would prefer hook up this drop-in hook and hook this class 3 like this way. It's called early light show elastic. Why is early? We start from day 1. Light and short. Once the elastic gets longer, you run into a risk that you might jeopardize the arch form, distort the arch form. Okay, so I prefer early and I prefer light and short. How light is light enough? I normally use 2 ounce coil, only 2 ounce. And this 2 ounce coil will produce an equal and opposite mechanic to push the motor back with this open coil spring and also bring the front teeth forward to solve the anterior crossbar. And this becomes much better mechanic. I love this one. I love this one. Again, the elastic that I use is 2 ounce coil. I am crazy about coil. And probably a lot of people who live in the city never have a chance to touch coil. And I do have coil garden called Chris Coil Garden. This is my coil. This is called Italian coil. This is called Chinese coil. And I do have Texas coil and Japanese coil. This one is 2 ounce. And this Chinese coil is the smallest coil in the world. It's only ½ ounce, which is roughly just 15 grams, very small. How small is that? Let me show you this one. This is my feet, and the coil is very, very tiny and very, very colorful. I love this Chinese coil. 2 ounces is roughly 60 grams, very light. And the reason why I have this coil garden is because I prefer to see coil in their natural habitat rather than in room or cages. I wanted them free. They were born free, supposed to set free. That's why I built this garden for my coil. It is rooftop garden. So no rat or snake, the predator. So rooftop only the eagle. So I have some device which is compact disc. So I can prevent the eagle to eat my coil. That's coil. Oh, I love this coil. Beautiful, beautiful bird. 2 ounce coil is the key. 2 ounce, 2 ounce. And the other side, we use open coils to create the space to push the front teeth forward. And in this situation, because we don't need the upright motor, so you can hook out the elastic here or here too. They both are okay. They both are okay. So they are okay. And this is number 3 is the open coil spring. So when you hook out the class 3 like this way, the open coil spring will push the front teeth forward, which perfectly fit into our mechanic because we want to bring the front teeth forward to stop the anterior crossbar. And the anterior biterable will help the patient to stop the anterior crossbar as well. And because patient has a deep bite, once patient bite the anterior biterable, and posterior become open bite. And this class 3 elastic will settle the posterior and reduce the posterior open bite. Isn't that wonderful? Every effect and side effect, we take advantage of both effect and side effect. That's Newton's law number 3. We start with this terrible situation. 5 months later, that's the result. And now it's easier for aligner. And look at this sabermetric analysis. It's amazing that within 5 months, did you see the big difference? Just 5 months, we flare in the upper incisor and we intrude the upper incisor. It will be very hard for aligner only to get this result in 5 months. I bet it will be very, very difficult to intrude the incisor and flare the incisor. Remember, the weak point from those studies, they talk about it is very difficult to intrude upper incisor. But with biterable and class 3 elastic open coil spring, it becomes piece of cake. Easy. So if it's powerful, why not do it? Some people will argue, Christian, we don't want to put braces. I insist, we want only use aligner. Those doctor has severe disease called obsessive compulsive disorder, OCD. Please, my dear friend, never learn from OCD. Learn from normal people like me. I am healthy, normal people. Now, it's easier. It's easier for aligner. How about posterior? Deep posterior crossbar like this. What would be the first step if you have deep posterior crossbar like this? Couldn't see the low posterior segment? Did you see how severe that was? What would be the first step? To organize your saw and come up with the right mechanic? The first step happened to be to decide how many millimeters to clear this posterior deep crossbar. So we opened up 4 millimeters. Not enough, because you didn't clear this crossbar. Open a little bigger, 6, barely. And 9 millimeters, it's too much, too big. So I take a wild guess, 7 millimeters is probably can clear this deep posterior crossbar without open up too much, because you really don't want to open up too much because the patient will not comfortable with huge open bar. So we decided to open 7 millimeters. Why? To clear this deep posterior crossbar. So we open up 7 millimeters right here, 7 millimeters, with posterior biterable. The, the posterior biterable is a little bit different from the anterior biterable. In the posterior biterable, I use glass ionomer cement type 2. It's soft and it's comfortable and it's very easy to handle. That's why in the posterior, I almost always use glass ionomer cement. Anterior, I use flowable resin. Canine, I can either use flowable resin or glass ionomer cement, both. How? Easy. First, you clean the surface. You don't have to add itching. Just dry the surface a little bit. If you don't dry the surface, that's still okay. It can work in the wet situation and just mix a piece of this glass armor and put it on the surface. And you can just add and add until you get 7 millimeters. That's easy, very easy. Believe me, it is very easy to use that glass ionomer cement. Key, biterable to raise the bite. And once you raise the bite, I put a buckle share screw. Put a lingual button, hook out this power chain. So that will give a buckle movement. 5 months in treatment. Guess how many millimeters we get for this buckle movement in 5 months? Let me draw this line and you'll be surprised. Wow, just 5 months, glass ionomer cement biterable and this buckle shear screw, BS screw, in just 5 months, we get 6 millimeter buckle movement. Buckle movement is very difficult, but just 5 months. This buckle shear screw is so powerful. And the failure rate for buckle shear screw is just 7%. We published 6 years ago in the Angle Orthodontics. If you are interested about buckle shear screw, you should read this article. 7%. And how people will say, argue, hey Chris, that kid is easy. Show me adult patient. Adult, the posterior buckle shear, the alveolar bone become very dense. So it's very difficult for you to upright. Watch carefully. You couldn't see the lower second molar. That show you how severe in the second molar area. Deep posterior crossbar. The way I did it, I put a braces because I want to speed up the treatment. I put a buckle shear screw. The buckle shear screw is supposed to stay away from the bracket. So I probably stay away from 5 millimeters away from. And the screw produce a pulling mechanic with this lingual button and power chain. Biterable in the other side, glass ionomer cement. And 2 months, I debunked it. Why not keep buckle shear screw a little bit longer? Oh, because this young lady have to study in United States. That's why we were in a hurry. So they only give me 2 months to get the job done. So 2 months, look at amazing. Did you see the second molar? Now we can see the second molar, low second molar. Huge improvement in just 2 months. If you want to learn more about this approach, we published in AJODO 3 years ago, and the mechanic was use buckle shear screw to upright the posterior crossbar in conjunction with biterable. And I was so lucky and so honored to get this CDABO Case Report of the Year award. I bet you heard this story many, many times. But because I'm so proud, I still want to show you one more time, just one more. because it is impossible for a country boy from Taiwan to receive this award. Do you know it's huge? Oh, I'm so proud. How could that possible? A country boy like a Christian can get this award. And there is a very famous statement, and I bet you saw this statement in many airports. When you go to the airport, and you will see this beautiful picture with this beautiful movie star. What's her name? Angelina Joanne. Okay, good. That lady. Oh, her name is so difficult to pronounce, but I love this lady. Oh, I love her husband even more, the Brad Pitt. Okay, go back to this statement. A single journey can change the course of a life. Oh, I love this statement. And I want to make a little bit change. A single school can change the course of a life. I was so excited when I adopted this mini school in my office. And suddenly I enjoy those difficult cases. Those cases, my friend, they don't want to treat it and they send it to me. Be honest with you, they are not my friend. They just want to torture me. So they send a lot of difficult cases, try to embarrass me. And later on, I find out this school, and that school virtually solved the majority of my difficult case. I love this case. I love this school. A single school can change the course, and they changed my life as well. How about rotation? Rotation in the last model is very difficult to solve. Let's go back to paper number 2 from our former president of AAO, Brent Larson. He talked about second molar rotation is very difficult to solve. Second molar. And how do you fix this second molar? I think the easier way to fix this second molar is pretend you didn't see it. Because it's second molar. Most people cannot see second molar. So why bother? But some patients, they insist they want to fix their second molar. So if that is the case, then you have to figure that out. How to derotate the second molar. Rotation in the last tooth require pulling, which is hard for a aligner. So we needed this moment. So can you tell me how can the aligner execute this moment? And the crown is very short, probably only 2 millimeters or 3 millimeters. Raymond screw. I put a Raymond screw, hook out this power chain with the button, and that produce a moment, and this moment will rotate the motor. And 7 months later, that's what we got. Isn't that amazing? We start like this. And with this Raymond screw, the pulling mechanic, that's what we get. Can we just use braces? Very difficult. The last molar is very difficult to derotate with aligner and with braces. Neither braces nor aligner. But screw, perfect fit into this mechanic scenario. And the Raymond screw, the failure rate is only 5%. We publish in this journal, and if you are interested about Raymond screw, you should read this article. Very important article. We published 5 years ago. And where is that Raymond located? It's right there. A lot of bone to work with. Some people was scared to put a screw in a Raymond. Oh, don't be. It's as easy as you can get. There are plenty of bone there. And and there's no nerve. People are afraid, "Oh, am I going to poke the nerve?" And the nerve is 10 miles far away. Don't worry about the nerve. Look at that. It's right here. The nerve is down below, far away. Rotate 50 degrees in 7 months. And now it becomes easy case for aligner. The rest is easy. But think about it. If you want to use aligner to derotate the second molar, it could be very difficult. I didn't say it's impossible, but it definitely was very, very difficult. Impaction. Let's start with the most popular impaction called upper palatal impaction. 14 months, right here. Wow. How do you solve this palatal impaction in 14 months? Key, open window, remove bone, and wait for auto eruption. Once you open the window and remove the soft tissue and hard tissue, and this palatal impaction has the potential to erupt by itself. So we open the window with electrosurgical unit. It took me 30 seconds. Just 30 seconds, it just removed the soft tissue. There is no hard tissue there. So you remove and take out the baby tooth down. 30 seconds or 1 minute. Okay, 1 minute. After eruption of the canine, it becomes easy for a liner to grab this one, the canine. If they don't erupt, how can you grab this impacted palatal canine? It's virtually impossible. Not impossible. It's very difficult. Never say never. Never say impossible. It would be very difficult. So you open up the window, you remove the soft tissue, and you wait for auto eruption for 4 months. And 4 months later, it's ready to get this aligner procedure. Labia impaction. Let me give you an easy one. This is an easy one. So how do you fix this impacted canine which overlay with lateral incisor? The way I did it is I use IGC screw and 3D level up. And this is in active form. So when I active, I bring that up right here. So I give 4 ounce activation. And this 4 ounce activation was sufficient to bring this canine out, back, and down. 3 directions. How can you have a 3 direction? Because it's a 3D lever arm, 3-dimensional lever arm. That's why you can adjust. So there are 2 tips to solve this is called overlap or transpose canine. Number 1 is keep it as high as possible. The higher the canine, the wider the alveolar bone, the easier you can switch. The higher, the wider the alveolar bone, the easier you can switch. So how can you keep as high as possible? 3D level arm. And number 2, design outward, backward, and downward force system. It has to be outward first, backward second, and downward 3. That sequence. How can you do that? 3D level arm. 4 months in treatment with this 3D level arm, we were able to get this result. Isn't that amazing? High impaction between central and lateral. Oh, this one is difficult because it's so high. And the crown was on top of the lateral incisor apex, the apex of lateral incisor. Beneath the central incisor. It's in between. The sinus is big sinus. Oh, Chris, can you go down a little bit? Good. So the way I did it, I put a IGC screw So how to put this IZC screw? Easy. I use this called Explore to make a physical rehearsal where I want to put a screw, which is an indentation. So the first step is perpendicular to the bone first. Once you engage 1 millimeter of cortical bone, then gradually change to an upright position. Why upright position? You want to stay away from the root and you want to engage the cortical bone. Upright position. Did you see that? First, we are perpendicular, catch the bone, and we keep screwing and change the direction. Gradually change the direction. If you are not comfortable with this approach, the easier way will be you watch this movie over and over and over and over until your brain get numb. So you'll be able to perform this technique. You see this video 10 times, 20 times, 30 times. I bet it becomes very easy for you to put this screw. Every screw that I put in, I will use this torque wrench to check the insertion torque. For this case, the insertion torque was 15 Newton centimeter. How could that possible? This is an 11 years old kid. The bone is pretty soft. How can you get 15 Newton centimeter? Two reasons for that. Number one, I was using a little bit bigger screw, which is 2 millimeter diameter. So I get more bone contact. Number two, I was putting in an upright position, which mainly cortical bone engagement. I was engaged on the cortical bone. That's why I get a little bit higher insertion torque. It's a 0, 5, 10, 15, right here. 15. Oh, this is a beautiful video. I didn't realize. Wow, that's beautiful. So even though the patient has huge sinus and the patient is a young kid, we still can put this IZC screw with 15 Newton centimeter insertion torque and 15 Newton centimeter is good enough to bring that down. Mainly cortical bone engagement. Upright position is the key. So when we started to activate this 3D lever arm, the reaction of the lateral incisor is quite interesting. The lateral incisor will tilt once the 3D lever has been installed. And when we bring that down, this lateral incisor will go back to the original. Did you see that? So people will ask me, Chris, how do you activate this 3D lever arm to get this result? Number one, you can bend this 3D lever arm like this. Or, so when we started, it's a straight piece. And then when you activate it, you use 3 jaw to bend it. So you activate this 3D lever arm. Or, if the canine already explored, you can stretch the canine and cut the extra power chain and hook it again. Or you change a new power chain if they already explored. Either way. 1, 2, 3. A 3-way. So you can change power chain or stretch power chain either way. It took me about 20 seconds in a visit. You know, when you do this approach, you activate every month. You spend 20 seconds and you charge $300. And the patient was saying, the parent was saying, oh, doctor, you only spend 30 seconds and you charge $300, $400. So I would suggest when you activate it, try to slow down and take as many photos as possible. So then the patient feel that $300 is worth it. So you slow down to justify $300 fee. But you only need 30 seconds. How about the failure rate of IZC school? We published 3 years ago in Ankle Orthodontics. It was 6%, which is pretty low. And where is this IZC located? It located outside 6 and 7. You have plenty of the bone to work with, my dear friend. Do not tell me you don't have IZC bone. You have a lot. Take photo. Beautiful diagram. My friend, Dr. Ramsey, draw this beautiful picture for me. Some people still feel uncomfortable to embrace the change because they are not used to use school. When I was a graduate student, I didn't have any idea about mini school. The only school that I used was Dr. Gene Robert, my mentor. He used dental implant to put in a retromolar area, which is a very big surgery at that time. And we don't have mini school 25 years ago. But later on, when people come up with the mini school, I find it so powerful. So I was so lucky to embrace this change. So I will encourage you, if you still have a doubt, to change the way you practice orthodontics. I think you need to make up your mind today. Be comfortable with the change. Otherwise, it will get punished. Because if young generation use mini school and you don't use it, it really will limit your reach of those difficult cases, for sure. Number 5, transalveolar impaction. Oh, this is very, very difficult. High transalveolar horizontal, very difficult. So I open up, I reach this high impaction, horizontal, transalveolar, put a button, hook out this power chain. I hook 2 power chains. Did you see that? Because I'm afraid this is too high. If one break, I have the other one. It's like insurance, buy the insurance. And I have this 3D lever arm, and with this 3D lever arm, and I curve to the socket because I want to bring that down, flip upside down, and bring into this socket. That's why I adjust this 3D lever arm as a curve. So IZC screw, 3D lever arm with headaches. I use 19 by 25 stainless steel. And this 3D lever only took me 1 minute to bend it. That's it. And attach to the button with power chain and activate it. How to activate? As I mentioned, you can stretch the power chain and cut the extra. Oh, it only took me 10 seconds. But you have to get very slow, okay? Otherwise, it will be very difficult to charge $300 or $400 per visit. So IZC screw and 3D lever, a must. You have to learn. You should learn, and you will, because it's so powerful. I cannot find other way to solve this transalveolar impaction. So if you are interested about this 3D lever arm and IZC screw, we published 2 articles in this issue, JDO, Journal of Digital Orthodontics, volume 59, that's last year. This case, here. And I want to take this opportunity to thank you, my mentor, Dr. Gene Roberts. All the publication that I have was under the guidance and the help of my mentor, Dr. Gene Roberts. He has did a tremendous job to help me to publish those cases and also to keep me under control. Otherwise, it's easy for me to get out of control. I want to take this opportunity, precious opportunity, to thank you, my mentor, Dr. Jean Robert. You did a wonderful job to coach a country boy like me. Thank you. The second article was published by my friend from French friend, Stephanie Ringo. He made an interview and to survey how I come up with those approach. It's very, very comprehensive review of how I come up with the idea to stop the infection, to use that school, that sort of thing. So I would strongly suggest you to read this article, and you can free download JDO at ijdo.pro. If you have any question, you can go to my website or you can go to my YouTube. By far, I put over 600 lectures on my YouTube. They are free. So why bother? Just go to the YouTube. Everything is right there. Every single slide. You can find it in my YouTube. Every single slide. I mean every. IDC school with 3D level is definitely a must for everyone if you want to solve difficult cases. Oh, okay. So it's right here. So we have the aligner take over. And some question will say, can the aligner guide high canine to the occlusion because it's very high? Why not use the 3D level to bring to here? Because the soft tissue and the hard tissue cannot keep up with this 3D level. 3D level is very powerful. So you better keep this way to have this soft tissue recover, regenerate by itself. So I use this aligner, and I hope this aligner can guide the high canine to the occlusion. But if you look at carefully, it's ear-fitting aligner. In other words, it's object. So how can you do it? Well, in dentistry, we talk about canine guidance, incisor guidance, and nobody ever mentioned about finger guidance. But in this case, I strongly suggest you use finger guidance, not your finger, the patient's finger. Ask the patient to use his finger to push this down and inward and downward, called finger guidance. It's as important as incisor guidance and canine guidance. With this powerful finger guidance, the finger guidance can help during the active eruption step. And the canine is right here. And final is right here. Just aligner and the patient's finger. That's it. Oh, I love this finger guidance. I love it. Hardest one. Oh, okay, hardest one. How to fix this one? Protrusion, gummy smile, mixing, impacted. Oh, very difficult. If our plan is set A and we need a close 6 and we need an upright 8, how can you do that with aligner? Huh? Key, buccal mechanic. And people will say, why you want to leave 3 minutes? 3 minutes is okay. The aligner can handle this 3 minutes. We are ready for the aligner because we want to shorten patient's total treatment time. And watch carefully. This clean check is not perfect. Why? Because at the end, we still have big overjet, 2 mm overjet, we still have N on class 2. And you may wonder why you want to leave this 2 mm overjet? And why you want to leave this end on class 2? Simply because this is just stage 1. We have 2-stage digitalization. And when during refine, once we upright the model, we can have the second statement and we digitalize the model in the second statement. Surgery. Easy to remove soft tissue like this way and put this Ramer screw for pulling. And when I look at this slide, the distance is too short. If I could try this again, I will put a little bit higher so I get a little bit longer distance. It will be easier. But we all make mistakes. If you are interested about Ramer screw, here is an article we published 3 years ago in Seminar in Orthodontics. Very good article. One more. How about this one? 3D level arm. Important. Upright position outside the root with 3D level arm. Now, 3 months. Time to remove the screw and 3D level arm. Just 3 months. Hard tip. Do not remove the bottom. It hurts. Wait 2 more months until the soft tissue and PDF stabilize. Now it's ready to remove the bottom. So 3 months in treatment, you only remove 3D level and screw. And wait 2 more months to remove this bottom. It will be easier for this patient. Wow, I love this buccal shear screw. What if no treatment for this infection? Well, one possibility will be it will erupt by itself. The other possibility will be it will fall down and start to migrate, and it become transmigration. Let me give you the other example. Canine, no treatment for 9 months. And guess what? It becomes transmigration. 6 months, 8 months. Did you see the difference? 9 months. So 9 months, we find it's a transmigration. We put the buccal shear screw with 3D level arm, and that's what we get. Wow, amazing result. Did you see that? Transmigration, buccal shear screw, 3D level, hard tip. How do you do this 3D level? I prefer to bend this U-shape. It's easier to hook up the power chain. And I prefer to round the end. It's easier to get into the square hole. And I also like to bend the end, burn and bend the end, secure. And finally, I love to use flowable resin to fix that. 3 tip. And this I use 19 by 25. So buccal shear screw and 3D level arm in 5 months we raise 8 millimeter. It is a must for every orthodontic, for sure. That's why there are so many. For example, ankylosis. How would you fix this ankylosis? Easy aligner case, except ankylosis. When you have ankylosis, first step, subluxation. Make sure you rock and roll, loosen up. After that, you use buccal shear screw to bring that up like this. And 5 months later, you're done. Wow, because this buccal shear provides a moment, 5 months in treatment. Done. If you cannot handle ankylosis, you probably wouldn't have this aligner case because he was sick somebody else. And what is the next step? The next step will be take this out. Don't waste your screw. Use alcohol gouge to clean it and put it back in. Make sure you make the tissue numb first. And you hook up the power chain like this. So you provide a moment to upright the second molar, as I showed you before. And how to screw. Easy. Watch carefully. The way I stabilize the mandible with my thumb and how I insert the screw, the hand position is important. And the screw I use is stainless steel, so it's very, very robust, very strong. Don't worry, it won't break. 30 seconds, easy yet powerful. To conclude my lecture today, conclusion number 1. The majority of my difficult pre-aligner case can be solved with screw. Chris, can you go here? Good. Conclusion number 2. I, Chris Chang, would not practice aligner without screw, because screw can give you a lot of freedom to treat those difficult cases. And number 3, about teaching. 15 years ago, I started sharing my success and failures with a small group of local doctors. Since then, the group has grown, and I am very lucky to be able to touch so many doctors in so many countries. It is truly an exorbitant privilege to be able to touch you, especially the younger generation. When it all started, I was like a kid looking for a star. But today, thanks to our president, Dr. Chris Roberts, and your AAO committee, I have found the galaxy. With that, I thank you for your attention.
Thank you, Dr. Chang. As usual, a beautiful and enlightening lecture. And we have some minutes left for the questions, and we've got a lot of questions here. I'm going to try to choose some. The first is related to the bite turbo. And she's asking, when you placed the anterior bite turbo and said it took 3 months, did you just let the patient go and the posterior teeth erupted spontaneously before you started aligner treatment?
Yeah, that's right. That's the point. So when you put the anterior bite turbo, you open up the posterior, but you don't want to open too much. So the key, the secret is when you put a bite turbo, use burr to just smooth the surface to get a incline plane, a slope. So that will reduce the amount of posterior open bite. So if you open 2 or 4 millimeters, should be okay. Just let it go, and they will practice. And if you want to make a little bit complicated for the patient, because if you only put a bite turbo and you charge a lot of money, they will say, oh, it won't worth it. So you can give them some tongue blade. Use tongue blade to create the Newton's law number 3, action and reaction, to push the front teeth forward. It's the other way to do it. So you can combine together. Thank you. That's a good question.
And I see. And some other questions related to the bite turbo, related to the risk of gingival recession, TMJ symptoms, and when it's time to remove it, if you have a lot of trouble and spend a lot of time removing these from the teeth.
No. You use high speed, should be okay. And high speed, it takes about 2 minutes. And the last piece, you can use white gauze to just crunch, so they will just fall down. And finally, you can use scatter to remove that. So the total time only maybe just 2 or 3 minutes. Should be easy. And the posterior bite turbo is even easier because the glass animal cement is very soft. By the time you want to remove, the patient already wear that down. So not too much there. Thank you.
And how often do you see the patient in order to control for gingival recession and TMJ symptoms?
I rarely see gingival recession. in those biturbal case. And for the TMD problem, very few. If they happen, and you can just prescription, give some medication. And I don't think that's a big problem.
Yes. Well, unfortunately, we don't have more time, and you should see the chat, the comments you're having from your presentation. People loved it, and the ones who couldn't get their questions answered, please email Dr. Chang through his website. He said he would be happy to answer everybody. And with that, Dr. Chang, we couldn't have started this conference in a better way. And for this informative presentation, as we conclude this session, please remember that evaluations, CE certificates, and transcripts are available from the Evaluation and CE Certificates tab on the main conference page. Please return to the conference schedule or My Itinerary tab and select your next session. Thank you.
Thank you, Jose. Obrigado.
Thank you.
Say hello to Fabia. Thank you.
Okay, thank you.